All right. So we're going to continue with our discussion of power analysis and effect size. So here's another example that is going to help illustrate these concepts. It's also posted on Blackboard for your reference. So this was a study that it was entitled "Use of Manometry for LMA Airway Reduces Post-Op Pharyngeal Laryngeal Adverse Events." Basically, that was a composite of sore throat, dysphonia, and dysphagia was the outcome that they chose to examine. And what they were looking at was the incidence or the rate of adverse events between patients who were randomized to have a manometer adjust their cuff pressure or not, just usual standard of care. And so what I've done is I've pulled in their abstract and then I pasted in the section from their power analysis. And so what they said was they were looking at, based on an incidence of these adverse airway complication rate of 42% with high intracuff pressure, meaning it was beyond what was manufacturer recommendations were. And they went with a power of 90%. So this is the first time we're seeing a higher power level. So their beta error is only 10%. And they went with an alpha level or a p-value of 0.05. And they were looking at reducing the rate of complications from 42% to 21%. So they were looking at a 21% difference in outcomes between the groups. That they estimated they would need 200 patients total, or 100 patients per group. So power was 90%, the beta error was 10%. So they need a larger sample size. The p-value 0.05 and their effect size, excuse me, was a small to medium effect size. They were using chi-squares. It was nominal data. Their independent variable was pressure limiting versus usual care, and their dependent variable was the rate of these adverse events, which was a yes/no. You see, their primary finding was they in fact found not a 21% difference, but they actually found a 32% difference in rate of adverse airway events, favoring use of the manometer. So what is the actual power of this study? So here's some questions for you. What effect does decreasing the beta error from 20% to 10% due to the sample size? Well, it increases it. Why do you think they chose a smaller beta error or greater power? Maybe they wanted to be much more confident, that reduce the risk of a type 2 error, of not finding a difference when in fact there really one is. Because if we think back to it, if we're willing to accept a 20% beta error, then there's chances are that we may end up having a lot more studies that are underpowered. And that may delay implementation of treatments. And maybe in this case, they felt, you know what, this really does make sense and it works, but we want to be very confident. We have to have strong power to base our conclusions on. The next question is, what effect does increasing the power have on the risk of a type 2 error? Well, it decreases the risk of a type 2 error, just based on what I just told you. So if we look at this, go back to the G-Power software, and this helps illustrate what effect the decreasing the beta error has on the sample size. So here's what we did. So I went in and inputted the data that they found with their original effect size. They're thinking a 21% difference. So they went with 90% or a 10% beta error. That gives them 182 subjects to achieve that power. They went with 200, so they were probably giving some attrition in there. I used a slightly different program to calculate that. Now, if you go to 80%, if to have 80% power, they could have gotten away with 136 subjects total between the two groups. So the answer to that is decreasing the beta error increases the sample size requirements. So what was their actual study power that they found? So I did a post hoc test here to see what power did they actually achieve with their given alpha, sample size, and effect size. See here, I inputted those in, and I actually put in their actual sample sizes and the sizes of the two groups. So it came out, they actually had 99% power to detect a statistically significant difference between the groups with their difference of 32%. So what type of sample size would they need? If you were to do a future study, follow-on study, you want to confirm these findings at your institution. You're going to do the exact same study design. How many subjects would you need to achieve 90% power? Well, you would need 76 subjects total, or 38 per group. Now, if I was to decrease this to 80%, that sample size would go down. What is the magnitude of that effect size? Well, it's pretty large. It's a medium effect size. So we said the effect size, you can see here, and actually if we do it over here and I calculate it, it actually will calculate an odds ratio for us, and so it's 5.4. So the odds were significantly greater odds of adverse pharyngeal laryngeal sore throat, essentially, in the usual care group compared to the manometer group. And so that odds ratio, it actually falls, what they found was between a medium to large effect size is what they found. What happens to the sample size if we decrease the p-value and hold the beta error constant? So if we take their same data, using in this case we're using a Fisher's exact test, looking at nominal level data between two groups and looking at the rate of outcomes. So yellow is a p of 0.05. The gray is a p-value of 0.025, so much more conservative. Before we would, we're trying to decrease the risk of a type 1 error. So, at 80% power, we need 136 with that given effect size of what they found. But it goes up to 168 if we use a much more conservative p-value in the future. So, sample size requirements. Here's a little nuts and bolts, down and dirty. Sample size is going to be increased if you decrease the p-value, you decrease the beta error, you increase the power of the study, or if you have a smaller effect size. You can get away with a smaller sample size requirements if you use a higher p-value, say 0.05 as opposed to 0.025. You increase the beta error, you go from 10 to 20%, which is what we usually do. Decrease power, 80%, and if you have a larger estimated effect size, which is what we discovered earlier in the saline bolus studies. So in summary, to calculate a sample size, you need to know the alpha error, the beta error, and the effect size. And investigators really should choose their effect sizes based on the best available evidence. And sometimes it's really just our best guess. of what we think the magnitude of the effect that we expect to see. And there's a lot of assumptions that we make and factors we have to consider, including logistics, time, and money. When you critique a study, always look at the what they call an a priori. I mean, they should be doing a power analysis before they execute the study in most circumstances. Or they should do a post hoc if they weren't able to do one. In some circumstances, you necessarily may not be able to do a power analysis. And you need to look in the discussion to see whether or not the authors felt the study was appropriately powered based on their findings. The most common errors in anesthesia research are type 2 errors, that the studies are underpowered. And that's one of the reasons why you tend to see meta-analyses done, and we'll talk about that in later weeks. Tito is going to go over those topics. Because we can pull these findings from these multiple studies and come up with a common effect size. And the other thing is, I think, consider downloading the G-Power software and learning how to use it. It's a very powerful tool. It's easy to use, and I think it really helps reinforce these concepts. With that, if you have any questions, please email your faculty, myself or Dr. Tubog.